Drugs to treat pain, non-opioid analgesics, and anesthetics. At the end of this content, students should be able to differentiate between the types of pain classifications, list the therapeutic effects of each of the drug classes, non-opioid analgesics, topical analgesics, and topical and local anesthetics. Determine the indications, contraindications, and precautions to follow for each of the drug classes discussed in this chapter. Educate the patient on dosing schedules, and describe the athletic trainer's role in the clinical management of acute and chronic pain. Pain in the biopsychosocial model. Pain is well defined as a subjective, unpleasant sensory and emotional experience associated with actual or potential tissue damage or abnormal functioning of the nerves. This can range in an etiology from headaches to a sprained ankle. Pain is a component of virtually all clinical pathologies, and management of pain is a primary clinical imperative. Just about everybody at some point in their life experiences pain. Approximately 100 million adults in the United States, more than the number affected by heart disease, diabetes, and cancer combined, suffer from some common chronic pain condition. Pain is one of the most frequent reasons for visiting a healthcare provider, and among the most common reason for taking medication. Each person perceives pain differently. The effectiveness of treatment for pain often depends on the constellation of biological, physiological, and social factors. The biopsychosocial model is helpful for understanding health and illness. This model reflects the development of illness through the complex interactions of biological, psychological, and social factors. Biological factors, such as genetics, and biochemical factors, such as the extent of an illness and injury, and whether the person has other illnesses, is under stress, or has specific genes or predisposing factors that affect pain tolerance or thresholds. Psychological factors, including mood, or the personality or behavior. Emotions such as anxiety, fear, guilt, anger, or depression, thinking that the pain represents something worse than it does, and that a person is helpless to manage it. Social factors such as cultural, familial, social, economic, and medical factors. This is the response of significant others, friends, or teammates to the patient's initial response to pain. When assessing and treating pain, it is helpful to classify or subdivide the presenting symptoms into types of pain. A consensus panel commissioned by the National Institute of Health, or NIH, uses decisions as a basis for classifying or categorizing pain into acute and chronic presentations. Pain comes into many forms, although acute and chronic pain are considered separately. A person can experience both simultaneously. Acute pain is sudden onset and expected to last a short amount of time, typically less than 6 months. Acute pain can be useful to the physiological process. Its adaptive purpose is to warn a person of a disease state or potentially harmful situation. This is typically linked clearly to a specific event, injury, or illness, such as a muscle strain, a severe sunburn, a kidney contusion, or a heartburn, for example. Most people can control many types of acute pain on their own with over-the-counter medications or a short course of more potent analgesics and rest. Acute pain can be sharp or dull, burning, shock-like tingling, shooting, radiating, fluctuating in intensity, varying in location, and can occur in temporal relationships with obvious noxious stimuli. Chronic pain is prolonged, lasting more than several months. Variously defined, this is typically 3 to 6 months, but certainly can be longer than the typical healing, and can be frustratingly difficult to treat. This type of pain typically does not have any useful biological value to patients or clinicians. Although improvements may be possible, for many patients suffering from chronic pain, a cure may be unlikely. Chronic pain can become so debilitating that it affects every aspect of a person's daily life. The ability to attend school, practice, or work, perform activities of daily living, or maintain friendships or family relationships can be affected. Essentially, it impedes the person's ability to participate in fundamental tasks of daily living and appreciate the basic pleasures of life. The pathophysiology of pain involves complex interactions between neural and immune networks within the peripheral and central nervous systems in response to afferent sensory stimuli that produce conscious experiences that we know as pain. Pain can be broadly developed into three classes: nociceptive pain, inflammatory pain, and pathological pain. Nociceptive pain is also known as physiological or protective pain. Acute nociceptive pain is physiologic, elicited only by noxious stimuli that act as a warning or protective signal. In some clinical situations, such as acute trauma or surgery, it is necessary to control nociceptive pain. In this case, the pain pathway can be interrupted by blocking the transmission with local anesthetics. Nociceptive pain may be controlled by administering opioids, such as morphine, for post-operative pain control, or tramadol, an opiate widely used to treat mild pain. Nociceptive pain can also be described as somatic or visceral pain. Inflammatory pain, often considered one of the cardinal features of inflammation, is caused by the activation of the immune system by tissue injury or infection. This is adaptive and protective by heightened sensory sensitivity after unavoidable tissue damage. Inflammatory pain assists in the healing of the injured body part by creating a situation that discourages physical contact and movement. Pathological, harmful, or maladaptive pain. Some pain is not protective, but rather harmful or maladaptive. This pathological pain is not a symptom of some disorder, but rather a disease state of the nervous system. This can occur after damage to the nervous system, but also in conditions in which there is no damage or inflammation. This is known as dysfunctional pain. Injury to the peripheral nervous system yields a complex anatomical and biomechanical change. Dysfunctional pain is commonly associated with other syndromes in which there exists substantial pain, but no noxious stimulus and no or minimal peripheral inflammatory pathology. Conditions that evoke dysfunctional pain include the following: fibromyalgia, irritable bowel syndrome, tension type or chronic headache, temporomandibular joint disease, and complex regional pain syndrome. Analgesics act in various ways on the peripheral and central nervous systems to achieve analgesia, or relief from pain. There are broad categories of analgesics that are as follows: non-opioid analgesic drugs, such as acetaminophen; non-steroidal anti-inflammatory drugs, such as the propionic acid derivatives, also known as ibuprofen; and opioid drugs, such as morphine and oxycodone. Acetaminophen. Acetaminophen is one of the most popular analgesics and antipyretic medications in the world. Over 29 billion doses of the drug were sold globally in 2009. Acetaminophen, also known as paracetamol internationally. It became popular in the United States in the early 1980s as an option for treating fever in children without the risk of Ray's syndrome. In the United States, about 50 million Americans use acetaminophen weekly for various conditions. Acetaminophen is available in a generic medication. Acetaminophen is available in a generic medication with a trade name including Tylenol, among others. Common conditions that acetaminophen treats include headache, muscle aches, arthritis, backache, toothache, colds, and fevers. Acetaminophen has a role in treating mild to moderate pain and moderate to severe pain in conjunction with opioids and reducing fever, antipyretics. Acetaminophen is widely used for reducing fever in people of all ages with minimal risks. The pain-relieving aspects of acetaminophen are facilitating through inhibiting neurotransmitters in the central nervous system. Although not fully elucidated, the analgesic effects are believed to be due to activation of the descending serotonergic inhibitory pathways in the central nervous system. As an over-the-counter product available in a convenient tablet or caplet form, acetaminophen is a popular choice for athletic trainers treating pain secondary to injuries such as sprains, strains, contusions, fever, and a headache. In the sports medicine setting, the primary route of acetaminophen administration is oral. Acetaminophen is absorbed in the small intestine, metabolized in the liver. Table 7.1 illustrates the pharmacodynamics and pharmacokinetics of an analgesic. Local anesthetics. The first local anesthetic, cocaine, was serendipitously discovered to have anesthetic properties in the 19th century. Local anesthetics provide short-term pain relief when applied to mucous membranes or skin. For most patients, treatment with local anesthetic causes the sensation of the pain to disappear first, followed by the loss of sensation of temperature, touch, deep pressure, and finally motor function. The drug may cross the epiderm barrier with the serratum corneum, the outermost layer of the epidermis, presenting the major obstacle to reach the A beta fibers and the C fibers, the sensory neurons in the epidermis. Once they have crossed the epidermis, the local anesthetics are absorbed readily into the circulation, increasing the risk of systemic toxicity. Table 7.2 illustrates local anesthetics onset and duration of action. Local anesthetics, the mechanism of action. Local anesthetics act on the cell membrane to prevent the generation and conduction of nerve impulses. These medications bind reversibly to specific receptor sites in nerve cell membranes where the pore of the sodium channel is blocked. When applied locally to nerve tissues in appropriate concentrations, local anesthetics can act on any part of the nervous system and on every type of the nerve fiber, reversibly blocking the action potentials responsible for nerve conduction. Thus, a local anesthetic in contact with peripheral nerve causes both a sensory and motor paralysis in the innervated area. These effects of clinically relevant concentrations of local anesthetics are reversible, with recovery of nerve function and no evidence of damage to nerve fibers or cells in most clinical applications. The chemical structure of common local anesthetics is similar among the canes, and drugs in this class have similar function within the body. Procaine is a typical local anesthetic of the ester type group. Esters generally are rapid hydrolyzing by plasma esterases that quickly metabolize the molecule in the bloodstream, contributing to the relative short duration of action of the drugs in the group. Lidocaine is a prototypical local anesthetic of the amide type group. These molecules are generally more resistant to clearance and have longer durations of action. There are exceptions, for example, benzocaine, which is poorly water-soluble and only used topically. Local anesthetics routes of administration. Local anesthetics are commonly delivered subcutaneously by injection, transdermally by patch, or topically on creams, gels, and in ointments, or via ophthalmic drops. Topical administration of local anesthetics can determine both the therapeutic effect and the extent of the systemic toxicity. Use of topical anesthesia makes injection necessary and is completely painless, factors that are particularly desirable in the sports medicine setting. The directions for use are generally given by the prescribing provider. The systemic absorption of the lidocaine patch is minimal. However, the overall understanding of its effectiveness of its analgesic is less understood. The lidocaine patch reduces ectopic transmission of pain signals to the dorsal horn of the spinal cord to interrupt pain signals from the sodium channels and the peripheral nociceptors in the localized area. The FDA has approved lidocaine transdermal patches for treating neuropathic pain and post-hepatic neuralgia. However, it has also successfully treated moderate to severe pain secondary to acute soft tissue and connective tissue injuries. Clinicians should advise patients to use reasonable precautions while using topical anesthetic creams, gels, and ointments, or transdermal patches. Some adverse effects. The most common adverse effects associated with topical anesthetics are administration site reactions such as burning, dermatitis, arrhythmia, pruritus, rash, skin irritation, and vesicles. A transdermal prescription patch. A 5% lidocaine patch delivers up to 12 hours of local pain relief. The FDA approved it to treat neuropathic pain and post-therapeutic neuralgia. This is common in the sports medicine clinic for acute and chronic conditions. Patients should be instructed to wear this for 12 hours on and then take 12 hours off. Analgesia may occur within 30 minutes of use, with minimal adverse effects. There are some non-sports medicine considerations to consider. Patients with a history of liver or kidney impairment should be cautioned. Patches can also be used to deliver opioids or fentanyl. Topical analgesics are medicines that numb and reduce the sensation of pain to the area, which they are applied. They are available as creams, ointments, solutions, eye drops, gels, and even sprays. Topical analgesics may be applied to areas such as the skin, inside the mouth, throat, nose, or even to the eyes. The pharmacological treatment is often considered the cornerstone of pain management. For prescribers, it is critical to determine the optimal pain management plan for an individual patient using a benefit to risk assessment to select the proper therapeutic agent. The prescriber must evaluate the potential for benefits with each pharmacological option and assess the risk for adverse effects. The athletic trainer and other healthcare providers treating the patient at regular intervals must frequently monitor the patient's pain and responses to medication plans. When implementing the prescriber's pain management plan, the athletic trainer should do the following: inform the patient of any modifications to therapy, educate the patient and any caregivers regarding the prescriber's treatment plan, ensuring that they understand all instructions, complete validated patient-reported outcome scales, discuss symptom-specific lifestyle modifications. This should include diligently complying with all treatment plans to avoid exacerbating the original injury. Perform non-pharmacological treatment modalities. Review the patient's drug therapy regimen, including dose, route, frequency, and duration. Monitor the drug therapy regimen with the patient, including efficacy, toxicity, misuse, and adverse effects. Educate the patient on safe use, storage, and disposal of medications, and schedule follow-up appointments. The athletic trainer should also monitor the patient's pain in response to the medication plan. The athletic trainer should be aware of health-related quality of life, or HRQOLs. Athletic trainers play an essential role in monitoring and evaluating the patient's response to the pain management plan. Be observant for signs of abuse or misuse in pharmacology, and discuss the overall treatment plan with your patient. In summary, pain management is a vital part of the therapeutic intervention plan. You might want to look at pain as the fifth vital sign. Athletic trainers often have frequent interaction with patients. We can help to minimize patient uncertainty as much as possible. We need a functional understanding of analgesics. We can start slowly with over-the-counter medications before incorporating prescription medications when possible, and regularly monitor our patients, and be sure to incorporate patient-reported outcomes, or PROs, when possible.